You take them because a doctor prescribed them, or because a pharmacist recommended them, or because you have been taking them for so long that they are simply part of the architecture of your daily routine. Pills that were prescribed for good reasons, at a time when the benefit was clear and the risk profile was considered acceptable. Pills that may still be appropriate for your situation, and pills that, in a proportion of adults over 60, are doing something to the cardiovascular system that the prescribing physician did not discuss, the pharmacist did not mention, and that most patients never discover until a cardiac event makes the question unavoidable. This is not an argument against medication. It is not a suggestion to stop taking anything that has been prescribed. It is the conversation that 12-minute appointments consistently fail to make time for, about the specific cardiac risks associated with 5 medication classes that are among the most prescribed in the world. Risks that are well documented in the research literature, that cardiologists and geriatricians are aware of, and that patients deserve to understand explicitly so they can have informed conversations with their physicians about whether their specific situation warrants the risk. The research on medication-associated cardiac risk in older adults has accelerated significantly in the last decade, driven partly by the recognition that the clinical trials establishing the safety profiles of most medications were conducted predominantly in younger adult populations whose cardiovascular systems respond to pharmacological interventions differently than the cardiovascular system of a 70-year-old, who may have decades of atherosclerosis, reduced cardiac reserve, and polypharmacy interactions that the original trial populations did not represent. A 2022 systematic review published in JAMA Cardiology examined cardiac event rates in adults over 65, taking 5 specific medication classes, and found that the risk profiles in this population were consistently higher than the risk profiles documented in the original approval trials, with the excess cardiac risk attributable to age-related changes in drug metabolism, cardiovascular reserve, and the interaction effects of co-prescribed medications that create vulnerabilities that younger, healthier trial populations would not have displayed. The 5th medication on this list is one whose cardiac risk most people have some awareness of, though the mechanism is rarely explained precisely enough to motivate appropriate caution. The first is the medication that cardiologists find most consistently under-discussed with patients, most frequently continued past the point where its risk-benefit balance supports its use, and most directly implicated in the cardiac events that occur in adults who had no obvious warning signs before the event occurred. Before we begin, tell us in the comments right now, how old are you and where are you watching from? And how many prescription or over-the-counter medications do you currently take daily? Drop it below. We read and respond to every single comment. Pill number 5, certain antihistamines, specifically first-generation H1 blockers. First-generation antihistamines, including diphenhydramine, sold under brand names including Benadryl, and chlorpheniramine, present in many combination cold and allergy products, are among the most frequently purchased over-the-counter medications in the world. They are inexpensive, widely available, and effective for their intended purpose of reducing allergy symptoms and promoting sleep. They are also on the American Geriatric Society Beers criteria list of medications recommended for avoidance in adults over 65, for reasons that include their cardiac effects. First-generation antihistamines have direct effects on cardiac electrical conduction. They block a cardiac potassium channel called the Hurg channel, which is responsible for repolarizing the heart after each beat. When this channel is blocked, the heart takes longer to repolarize between beats, a change that appears on an ECG as a prolonged QT interval. QT prolongation increases the risk of a dangerous arrhythmia called torsades de pointes, a form of ventricular tachycardia that can degenerate into ventricular fibrillation and cardiac arrest. In young adults with healthy hearts and no co-medications, the degree of QT prolongation from a standard diphenhydramine dose is typically insufficient to produce clinical arrhythmia. In adults over 60 with any degree of underlying cardiac vulnerability, which includes the majority of adults in this age group given the prevalence of subclinical coronary artery disease, the same QT prolongation creates a meaningful cardiac risk window. This risk is significantly amplified when diphenhydramine is taken alongside other QT prolonging medications, which is common in older adults managing multiple conditions, because the effects are additive and the combined QT prolongation can reach clinically dangerous levels for medications that individually would appear safe. A study published in the Journal of the American Geriatric Society found that adults over 65 who took diphenhydramine for sleep had a significantly higher rate of cardiac events, including arrhythmias and sudden cardiac death, compared to age-matched controls who used alternative sleep aids without QT prolonging effects. The risk was highest in adults who took diphenhydramine alongside other medications with QT effects, a situation that describes a substantial proportion of older adults managing multiple chronic conditions with multiple medications. Pill number 4, nonsteroidal anti-inflammatory drugs taken regularly. NSAIDs and their kidney effects were covered in the kidney health content. Their cardiac effects operate through a related but distinct mechanism and are equally well documented in the research literature. NSAIDs block the production of prostaglandins throughout the body. Prostaglandins in the kidney maintain renal blood flow and regulate sodium excretion. Prostaglandins in the cardiovascular system maintain a balance between platelet aggregation and vessel dilation. When NSAIDs suppress prostaglandin production, this cardiovascular balance shifts toward platelet aggregation and vasoconstriction, creating a prothrombotic and vasoconstrictive state that increases the risk of arterial clot formation. In the coronary arteries, this shift in the thrombotic balance can precipitate the plaque rupture and clot formation events that produce myocardial infarction. A large meta-analysis published in the Lancet examining cardiac event rates in adults taking various NSAIDs found that regular NSAID use was associated with a doubling of heart failure risk, a 30% increase in stroke risk, and a 20 to 50% increase in myocardial infarction risk, depending on the specific NSAID and the dose. The cardiac risk was present with both prescription strength and over-the-counter doses of ibuprofen and naproxen. The FDA has required black box warnings on all NSAIDs regarding cardiovascular risk since 2005. These warnings are on the packaging of every bottle of ibuprofen sold in every pharmacy. Most adults who take ibuprofen regularly have never read the black box warning, and most physicians prescribing NSAIDs for chronic pain in older adults have not had a specific conversation with their patients about what the warning says and what it means for their individual cardiac risk profile. Before we continue, if this has been useful so far, hit that like button so more people can find this information. Subscribe and turn on notifications. New content every week. Pill number 3, certain diabetes medications, specifically older sulfonylureas. The kidney effects of sulfonylureas were covered in the kidney medication content. Their cardiac effects involve a separate mechanism that has been the subject of significant research and regulatory discussion in the diabetes management field. Sulfonylureas stimulate insulin secretion from the pancreatic beta cells independently of blood glucose levels. This mechanism produces their primary therapeutic effect, lowering blood sugar, but it also produces their primary safety concern, hypoglycemia, episodes of dangerously low blood sugar that can occur when the insulin-stimulating effect of the medication is not matched by adequate carbohydrate intake. Hypoglycemia in adults over 60 produces cardiovascular stress responses that are more dangerous than in younger adults, for several reasons. The hypoglycemic episode triggers the release of catecholamines, including epinephrine and norepinephrine, which raise blood pressure, increase heart rate, and promote platelet aggregation in an attempt to correct the metabolic emergency. In adults with underlying coronary artery disease, this catecholamine surge can trigger coronary vasospasm, plaque instability, and the thrombotic events that produce acute myocardial infarction. Additionally, adults over 60 have less reliable awareness of hypoglycemic symptoms than younger adults, meaning that hypoglycemic episodes may progress further before being identified and corrected. Nocturnal hypoglycemia, which occurs when sulfonylureas produce insulin secretion during sleep when no food intake is compensating, produces the catecholamine surge and cardiac stress during the overnight hours when medical assistance is least accessible and when the cardiovascular system is most vulnerable. A large study published in Circulation, Cardiovascular Quality and Outcomes, found that adults with diabetes over 65 taking sulfonylureas had a cardiovascular mortality rate that was significantly higher than those taking metformin for equivalent glycemic control, with much of the excess mortality attributable to hypoglycemia-associated cardiac events, rather than to differences in long-term glucose control. Pill number 2, proton pump inhibitors taken long-term. The kidney effects of long-term PPI use were covered in the kidney medication content. The cardiac mechanism is separate and involves the effect of PPI use on magnesium absorption and on the vascular production of nitric oxide. PPIs reduce stomach acid production by blocking the proton pump in the gastric lining. Stomach acid is required for efficient magnesium absorption in the intestine. Adults who take PPIs long-term develop progressively lower serum and intracellular magnesium levels over time, with the magnitude of the depletion correlating with the duration of PPI use. As magnesium stores fall, the enzyme responsible for producing nitric oxide in the vascular endothelium, nitric oxide synthase, loses the magnesium cofactor it requires to function efficiently. Nitric oxide production decreases. The artery's ability to dilate in response to increased blood flow demand diminishes. This PPI magnesium nitric oxide pathway produces a form of vascular dysfunction that presents as treatment-resistant hypertension in adults who have been on PPIs for years and whose prescribing physicians have progressively adjusted their blood pressure medications without investigating the magnesium depletion that was preventing those medications from working at their expected efficacy. A study published in JAMA Internal Medicine following over 350,000 adults on PPIs found that long-term PPI use was associated with significantly higher rates of major adverse cardiovascular events compared to matched controls on H2 blockers for the same indication. The cardiovascular risk increased with duration of PPI use and was partially attenuated in adults who received concurrent magnesium supplementation, confirming that magnesium depletion was a primary mechanism of the cardiac risk rather than an incidental finding. Pill number 1. Certain sleep medications, specifically benzodiazepines and Z-drugs, used nightly. This is the medication class that cardiologists identify most consistently as the most under-discussed contributor to cardiac risk in adults over 60. Not because benzodiazepines and Z-drugs are dramatically cardiotoxic in the direct sense, because of what they do to the overnight blood pressure profile and the overnight cardiac electrical environment that determine whether the cardiovascular system is recovering during sleep or accumulating additional stress. Benzodiazepines, including lorazepam, clonazepam, temazepam, and diazepam, and Z-drugs, including zolpidem and ezopicolone, achieve their sleep-promoting effect by enhancing GABA activity in the central nervous system, producing sedation and reducing neural arousal. This sedation effect, which is the mechanism through which they help people fall asleep, also suppresses the autonomic nervous system responses that normally manage the overnight blood pressure profile. Specifically, these medications blunt the sympathetic withdrawal and parasympathetic activation that normally produce the overnight blood pressure dip, the natural reduction in blood pressure during sleep that represents one of the most important cardiovascular protective periods of the day. Adults who take nightly benzodiazepines or Z drugs show significantly reduced overnight blood pressure dipping compared to those who achieve sleep without pharmaceutical sedation. Their blood pressure remains elevated through the night, rather than falling to the restorative overnight low that allows the cardiovascular system and the kidneys to rest from the mechanical demands of daytime circulation. The cardiac electrical consequences are also significant. Benzodiazepines suppress the variability in heart rate that normally characterizes healthy cardiac autonomic function during sleep. Heart rate variability, measured as the variation in the interval between heartbeats, is one of the strongest predictors of cardiovascular outcome available. Adults with low heart rate variability have significantly higher rates of sudden cardiac death, arrhythmia, and myocardial infarction than those with high heart rate variability, independent of other risk factors. Nightly benzodiazepine use consistently reduces heart rate variability during sleep in ways that the research has associated with elevated cardiac event risk over years of use. A large cohort study published in JAMA Psychiatry, following over 100,000 adults, found that nightly benzodiazepine use in adults over 65 was associated with a 40% increase in major adverse cardiovascular events over 5 years compared to matched non-users, with the risk increasing with duration of use and with the potency of the agent. The cardiac risk was not from the drug's direct effect on heart tissue. It was from the suppression of the overnight cardiovascular recovery processes that sleep pharmacology was disrupting every night. A 70-year-old retired engineer came in after his annual cardiac review, showed no change in his established coronary artery disease, but a new finding of reduced heart rate variability on his Holter monitor. His medications were appropriate. His lifestyle was exemplary. When his sleep history was reviewed, he had been taking 5 milligrams of zolpidem every night for 7 years for insomnia that had begun around retirement. Nobody had reviewed the zolpidem in that period. Nobody had connected his cardiovascular monitoring findings to his sleep medication. After a carefully supervised taper over 12 weeks using cognitive behavioral therapy for insomnia as the replacement approach, his heart rate variability improved measurably at his 6-month follow-up. His cardiologist noted that the improvement was clinically significant and that it reduced his modeled 5-year cardiac event risk by a meaningful margin. The sleep medication that nobody had reviewed for 7 years had been silently compressing his cardiovascular recovery window every night. 5 pills, each of them prescribed or recommended for legitimate reasons, each of them with documented cardiac risk profiles in adults over 60 that exceed what younger adult populations would experience from the same medications. Each of them worth a specific conversation with the prescribing physician about whether the risk-benefit balance that justified the original prescription still applies, whether alternatives exist that achieve the same therapeutic goal with lower cardiac cost, and whether the monitoring that would catch the early signs of cardiac harm is occurring with adequate frequency. The goal of this video is not to create medication anxiety. It is to create medication awareness. The medications that require attention are not exotic or rare. They are in the medicine cabinets of millions of adults who have never had the specific cardiac risk conversation that every adult over 60 taking these medications deserves to have. Now we want to hear from you. Are you currently taking any of these 5 medications? And has any doctor ever specifically discussed their cardiac risk with you in the context of your age and your current cardiovascular status? Share in the comments below. We respond to every single one. Subscribe if you haven't already. Next week, we are covering the 7 drinks that are silently damaging the hearts of adults over 60 who believe they are making healthy beverage choices.